What's up, guys? I'm gonna wait a little bit before we get into all of the questions, just to kind of get our audience up a little bit. But today we are going to be going over the big three content areas. Who my show is on. We're going to be going over the big three content areas per your guys' request. And then at the end, I've thrown in a couple other subjects that are less tested, but just as important that you know in terms of getting as many questions on your boards right as possible. So we're going to go over MSK, Neuro, and Cardiopulm. We'll alternate. It'll be MSK, then Neuro, then Cardiopulm, MSK, Neuro, Cardiopulm. I've got 26 questions total for us to go through this evening. So we're going to wait just a few minutes to see if we can get up in the double digits. And once we get a few more people on, we will go ahead and get started. I am well aware that we are, let's see, it's like 9 to 10 days out for many people's boards exams here in January. I forgot what month we were in for a second. Just a couple of heads ups. After the January boards, I will probably take 1 to 2 weeks off of the live content, just so I have a couple of weeks to try to amass as many NPTE practice questions as possible to just help me prep for Sunday nights before the April boards, but then I'll jump right back in. I'll also try in that time that I'm not doing lives, I will try to spend more time on weekends creating videos that I can post throughout the week. I've been really slacking on that recently just because this takes up a lot more time than I initially expected it to. Anyway, so that's just a couple of updates coming up. After next week, I'll probably take a couple of weeks off just to get as many questions put together as possible for the next round of boards. So let's just go ahead and jump right in. We're starting with MSK. A patient presents with lateral shoulder pain and weakness with overhead reaching. Special testing reveals pain with resisted abduction at 90 degrees and a positive Hawkins-Kennedy test. Which structure is most likely involved? A. Subscapularis, B. Supraspinatus, C. Teres minor, or D. Long head of biceps. Guys, go ahead and submit your answers. Engaging with the material is going to make it stick better. So the more you engage, the better it'll stick in your brains. So I'll read one more time. A patient presents with lateral shoulder pain and weakness with overhead reaching. Special testing reveals pain with resisted abduction at 90 degrees and a positive Hawkins-Kennedy test. Which structure is most likely involved? Just joined to say thank you. Just passed my exam. Hey, super proud of you, Solis. B Solis. Go do great things now. I'm super, super proud, though. Way to go, dude. All right, let's go ahead. We only have a handful of people on, so we will just go ahead and go over the correct answer. And as you can see from my highlighting, the correct answer is B, supraspinatus. So supraspinatus is commonly involved in impingement and painful arc with overhead motion. So remember where it said lateral shoulder pain, right? Just be keeping in mind which tendons would present as lateral pain if they were impinged. Subscapularis is your internal rotator. It's coming up underneath and across. So even though it does attach to the lesser tubercle, it's less likely to get impinged under that acromion. Teres minor would be more painful with resisted external rotation, not resisted abduction. And then biceps may cause anterior pain and get impinged anteriorly, but not laterally. So answer is B, supraspinatus. All right. A patient with Parkinson's disease would most likely demonstrate A, spasticity, B, ataxia, C, rigidity, or D, hypotonia. User, it's good to see you, dude. One more time. A patient with Parkinson's disease would most likely demonstrate A, spasticity, B, ataxia, C, rigidity, or D, hypotonia? So that's a few times when we watched this YouTube vid. I'm glad you did. I'm glad you passed B Solus. That makes me feel good. If I even had a small amount of influence on your studying, that makes me feel good. Okay, got a couple people that have submitted their answers. I really encourage you guys to be as interactive as possible. TRAP, resting tremor, rigidity, akinesia, and postural instability. Very good. Okay, let's go over the answer. The answer is, C, rigidity. We do not frequently see spasticity in patients with Parkinson's. Rigidity is one of those cardinal signs described as either lead pipe or cogwheel. Ataxia is not really common. That's obviously more common with cerebellar degeneration or cerebellar infarcts. And then hypotonia is the opposite of what we expect to see, right? We expect to see hypertonia. So let's go over number 3. A 72-year-old patient with COPD presents with a barrel chest, prolonged expiration, and is pursed lip breathing when you arrive to evaluate them. What is the primary purpose of pursed lip breathing? A, increase inspiratory volume. B, improve diaphragm strength. C, reduce oxygen demand. Or D, decrease airway collapse. Give you guys some more time to answer. I'll read it one more time. A 72-year-old patient with COPD presents with a barrel chest, prolonged expiration, and is pursed lip breathing when you arrive to evaluate them. What is the primary purpose of pursed lip breathing? A, increase inspiratory volume. B, improve diaphragm strength. C, reduce oxygen demand. Or D, decrease airway collapse. Do you have a sheet of like all your mnemonics? My mom's favorite BF just joined. I'd have to scour my notes. Yeah, no doubt. Okay, we will go over. All right. The answer is D, decrease airway collapse. So the primary function of pursed lip breathing is that you're blowing against positive airway pressure. So because I'm pushing against that positive back pressure, and let's just say increased, not creased. It prevents my alveoli from being able to collapse as quickly, which means I have more time for gas exchange. And remember, COPD is not an issue with being able to inspire enough, it's being able to expire all of the CO2, right? And so the problem in COPD is that you get airway collapse, there's not adequate time for gas exchange to occur, so you don't have enough time for CO2 to, hey, Northgate, good job, dude. Way to go, buddy. There's not enough time to allow for that CO2 and oxygen to exchange, and so that CO2 builds up in their system and they can't expire. That's why you get that. That's why people with COPD tend to have that wheezing on expiration. And so it's not an issue with them not having enough inspiratory volume, it's an issue with not having enough time for gas exchange to occur. And so pursed lip breathing, pushing against that increased back pressure, allows time for those alveoli to stay inflated, allow gas exchange to occur, and then they can expire out more CO2. Maggie, you're getting a lot of static buildup in your fur, it sounds like, buddy. All right, number 4. A patient reports numbness in digits 4 and 5 and weakness with finger abduction. What is the most likely nerve involved? A, median, B, radial, C, ulnar, or D, musculocutaneous? And if you know your sensory distributions, even if you didn't know what nerves innervated the intrinsics of the hands, if you know your sensory distributions, this should be a chip shot question. Very good, Banks. I'm assuming that's how you say with all the interesting fonts there. Banks. Okay, and it looks like many of you are getting this as a chip shot question, so let's just go over it real quick. User, I'm trying to be a little bit more efficient with our time, buddy, because I know that it's already late where you're at, so I'm trying to make sure that we're efficient. All right, ulnar nerve. So the median nerve would result in wrist flexion weakness, right? Because it gets nearly, a large majority of the anterior forearm, right? And so we're going to have a lot more issues with wrist flexion. And you would also get numbness in the lateral fourth finger and then digits 3, 2, and 1. Radial would result in posterior hand numbness, right, and weakness of wrist extension because radial nerve gets everything in the posterior compartment of the forearm. And then musculocutaneous has no sensory or motor distribution to the hand, right? It does have some sensory distribution to the forearm, but not all the way down into the hand. Ulnar nerve, if it says fourth and fifth digits sensory wise, ulnar nerve, okay? Easy peasy. I think about it all the time because my daughter sleeps with her head like this when I'm putting her down, and it sits like my elbow rests on the armchair and it compresses my ulnar nerve. And if I fall asleep in that armchair, I will wake up with this whole part of my hand. Pass my NPTE for PTA. Thank you for your practice questions. Hey, it was a pleasure, buddy. And if I got to be a small part of your success and just helping you study, I'm super, super proud to have gotten to work with you. So thank you for stopping in and letting me know. That makes me feel really good that many of you who I've gotten to interact with on here are doing so well. And I missed something. On extension, claw sign, and OK sign non-flexion. Not 100% sure if that's talking about my question or not. Okay, number 5. A 68-year-old presents 2 days status post right MCA stroke. The patient demonstrates left-sided weakness and impulsivity. Which additional impairment is most likely present? A, expressive aphasia, B, left unilateral neglect, C, apraxia, or D, ataxia? I'll read it one more time for you guys, my friends. A 68-year-old patient presents 2 days status post right MCA stroke. The patient demonstrates left-sided weakness and impulsivity. Which additional impairment is most likely present? A, expressive aphasia, B, left unilateral neglect, C, apraxia, or D, ataxia? Trent, honestly, I didn't see you join. I was wondering if you were going to be here. All right, you snuck right past me, but it's good to see you, dude. Okay. I'm getting used to waiting for a certain many of you who guys have been with me from the early days of these night schools. The answer is B. Right hemisphere strokes lead to left neglect, poor insight, and impulsivity. Aphasia and apraxia are more common with less left hemisphere strokes, right? And then ataxia is going to be a result of a cerebellar infarct. So good job, guys. No one was tripped up by that. It doesn't look like. But yeah, I get used to seeing your guys' names, and I just kind of wait to see who shows up. If all of my regulars are here. Okay, any questions about anything we've gone over so far? I feel like for the most part you all are crushing these, and so I didn't figure you all have any questions. So just post them if you got them. Okay. Okay. A patient status post cabbage is post-op day number 2. Heart rate is 110, BP 138/84, and SpO2 92 on room air. Let's assume that this is at rest because it hasn't said anything about them having gotten up. Okay. What is the most appropriate PT action? A, hold therapy. B, perform resistive exercises. C, perform high-intensity interval training, or D, begin low-level ambulation. FYI, we are recommending you to the classmates that are taking their exam in April. Well, thanks, dude. I really appreciate it. Just a heads up. Yeah, no problem. Just a heads up. After this round of boards, not this week, but next week, I'm going to take a couple weeks off just so I can try to amass as much content as possible in terms of practice questions. I'll try to do a better job of utilizing my weekends for making practice question videos that I can post throughout the week. So I will take a couple of weeks off the last weekend of January and the first weekend of February, just so I have time to try to put some more questions together for you guys. I am doing one next week. Yeah, I'll do one the last weekend before your guys' boards. I don't want to leave you hanging there. No indication of any emergency, and the patient needs extra caution since post-op day 2. So when I take my boards next year, I should assume it's at rest unless told otherwise. Here's what I would say. It has not said that you have initiated exercise yet. Okay, so if I was just reading this question, I guess my assumption would be at rest because it didn't say we intervened yet already. So that's what I would say. Okay, many of you guys have answered. So let's go ahead and look at the answer choices. Okay. Oh. All right. D, begin low-level ambulation. This is going to prevent secondary complications like pneumonia and blood clots. It's going to improve circulation. We need that angiogenesis to be stimulated to help recover. And it's going to help appropriate vitals, right? So this, or at a high resting heart rate, some of that probably just has to do with the fact that the circulatory system has been impacted by surgery. Could also be related to the fact that they're in pain, so maybe their sympathetic nervous system is stimulated some. Also, this is a little high, but nothing crazy, not worried about that. And this is a little low. They just had open heart surgery. It's going to take some time for that heart to recondition after that trauma. So, begin low-level ambulation. These two are just too high level for post-op day 2. Certainly C, but even B. The thing with resistive exercises is they are like told by their RNs and their cardiologists, don't Valsalva, right? And so if we begin resistive exercises, we got to worry that, well, I say we got to worry, we got to make sure that they have been educated on not Valsalvaing. If they Valsalva post-op day 2, it's just going to, lead to potentially much greater complications and a lot more pain. And then holding therapy, just like our friend said, Angel. Yeah, there's no indication of emergency, so there's no reason that we need to hold therapy. Oof. Okay, number 7. A 15-year-old football player presents to PT after sustaining a knee injury 3 days ago during practice. Based on his subjective information, you suspect an ACL sprain. Which test best assesses ACL integrity? A, Lockman, B, McMurray, C, posterior drawer test, or D, valgus stress test? And like you guys said, the answer is A, Lockman. It's the only test on the list that tests ACL integrity. McMurray tests meniscus, posterior drawer tests PCL, and valgus stress tests MCL. Do you guys know? I need a version of this when I go for my SCS. I have my NCS. I'm probably not the guy you want to learn SCS material from. Is there a specific ACL special test that is more specific in the acute versus chronic injuries? That's a good question, Quarter. I don't think so. I will say that Lockman, just from a research standpoint, Lockman has greater sensitivity than like the anterior drawer test. but I don't think that that's something that they expect um, entry level to be common knowledge. Maybe you guys learned that. Uh, it has higher sensitivity and specificity, yeah. And so I know that clinically speaking, people tend to use, like the colleagues I have tend to use Lachman more frequently, even though anterior drawer test is a test to assess ACL. But yeah, but I believe Lachman is kind of the more widely used one in the clinical settings that I've been in, at least. Pivot shift does like to come up though. Yeah, 100%. But that was a good question, Quarter. I'm trying to remember exactly. Go back to it. More specifically, acute versus chronic. I don't think so. Like in terms of acute versus chronic, I think the behavior should be the same because there's a lack of control in tibial and uh, anterior tibial translation, right? And so I don't expect that one would be more sensitive in an acute stage versus a chronic stage. But that's just me guessing. Definitely reach out to your ortho faculty. Okay, a 55-year-old with traumatic brain injury presents with agitation, confusion, and inconsistent command following. The patient is oriented only to person. What Rancho Los Amigos level best describes this patient? A, level 3, B, level 4, C, level 5, or D, level 6? Definitely know your Rancho levels. These are questions that come up for sure. For sure. May not be a ton of them, but if you can distinguish the different levels of Rancho Los Amigos, you'll be good. Several of you, we got 33 on, so I'm going to give a little bit more time before we go over the right answer. I'm trying to think. Has anyone been following me? NPTE prep, let's go. Has anyone been following me since I first started this when I was on that big post-it note board with like Sharpies? Have any of you guys been following my NPTE night school since the very beginning? Yeah. Oh my gosh, dude. I just feel so bad because my handwriting is kind of garbage. And so you guys are yeah, I just can't ever remember. I forget if it's like Northgate uh was with me that whole time too, I think. And so yeah, my handwriting is terrible. And it obviously took way more time to write questions out on paper than it does to type them out on Google Docs. Okay. So the answer is B, level 4, confused, agitated. So this is like the defining characteristic, right? Confused, agitated. Agitation, only oriented to person. Confusion, right? Inconsistent command following. So level 3 would be localized response only. So that's like you give them a stimulus, like for instance, a pain stimulus, and they localize to that pain response. And so you pinch their arm and they pull their arm away, right? You pinch their leg and they pull their leg away. Whereas level 2 is like a non-localized response. So you pinch and they just have like a general, um, oh gosh, I can't think of it, a general reaction against the pain stimulus. Level 5, confused but appropriate, so they'll be less agitated in level 5 state, be a little bit more oriented. And then level 6, emerging goal-directed behavior, so they should be able to have more consistent command following, albeit shorter commands, like not a ton of multi-step commands. Okay, number 9. A patient reports dizziness, nausea, and pallor during exercise. Blood pressure drops from 128/80 to 98/64. What should the therapist do first? Continue at a lower intensity, provide water, stop exercise immediately, wait until the patient's color returns, and then assess SpO2. Okay, thank you guys for interacting. There's only a handful of you that have answered, so I'm going to give it a little bit more time. While I'm waiting, I don't know how many of you have joined since I made the announcement. I will be on next Sunday because I want to make sure I give you guys one more night before the week of the January boards. And then I will take 2 weeks off just to give myself time to write more questions and create more content on this side of things, and then I'll jump back in. I will try to post more regularly. I've been doing a really bad job of that just because there's a lot of busyness going on in my work and personal lives as well. And so I haven't been able to devote as much time to just video creation. So I'll try to do that in those 2 weeks after the January boards. Okay. The answer is C. Stop exercise immediately. Hypotension, dizziness, and pallor are all signs of exercise intolerance. Continuing would be unsafe. Water's not a priority. And delaying assessment is also unsafe. So if you're just waiting for them for color to return. So the very next thing, what would be the very next thing you guys did? I had my first patient with a 50 to 60 SVP orthostatic drop last week, and it was crazy. Yep. Reading the questions and seeing it in real life. Yep. 100%. What would be the very next thing you guys would do from here? So you stopped exercise. This is their blood pressure. What's the very next thing you're going to do? Lay them supine, 100%. That's going to help venous blood return from the legs. Hopefully, it should pretty quickly increase blood pressure. This is when I would start um, frequently monitoring vitals. Could this be an example of severe dehydration or orthostatic hypotension? If not Trendelenburg, that's a good. Elevate the legs too. Yeah, absolutely. So you can put them in hook lying. If you don't have a hospital bed that goes into Trendelenburg, then you might just start putting wedges under their legs to get their legs higher than their head. You could also put it on a Swiss ball. It could be an example of severe dehydration. I would imagine if they were severely dehydrated, though, quarter, that ankle pumps could help. That you would have seen a low blood pressure from the get-go and not exactly just as a result of initiating exercise. Um, Severe orthostatic hypotension potentially, it depends on what you were having them do, right? So maybe you got them up and you had them stand for like a minute or so and they didn't get super dizzy, and then you had them start walking. So from a technical standpoint, if you're testing someone for orthostatic hypotension, you're supposed to have them up for 5 minutes, and you're supposed to take blood pressure at 1 minute post standing, 3 minutes post standing, and 5 minutes post standing. And so if you just like got them up and they were up for about a minute and you're like, yeah, they look fine, and then they start walking, well, there hasn't necessarily been enough time for us to see that total drop in blood pressure that we might see. And so it could be a result of orthostasis, especially if this person has been in bed for the last few days, right? Because our body, it does not take long for our cardiovascular system to decondition. And so usually in the hospital, I would see two things. People would get unstable orthostatic when we got them up, and they would retropulse, because being in bed for a couple of days like sort of resets your sense of what is like 0 degrees or what is upright. And so I got a lot of patients in the hospital that would retropulse just because they'd been in bed for a few days. Okay. A 68-year-old arrives to his PT evaluation with a diagnosis of lumbar lateral stenosis. Which of these behaviors is he most likely to report? A. Increased pain with bending to tie his shoes. B. Relief with extension. C. Pain relief with walking downhill. Or D. Symptoms improve with flexion. You know, a lot of D. A lot of answer choice D. Whenever I see Quarter agree with me, I know I got it right. Quarter, he's got high expectations. It sounds like user thinks you're going to be that perfect score this year. How many questions we got tonight? I got 26. I've got 26 tonight, and we're just alternating MSK, Neuro, and cardiopulm. and then I've got a handful at the end. Posterior tilt flexion, correct. I've got a handful at the end that are different systems or multi-system. So this would also be true, just so you know, the answer to this question would also be true if this was central stenosis. I didn't put central stenosis because that is more of a neurologic thing. If they're having, we think central stenosis more as like an emergent situation that they need to get surgically taken care of, right? Or neurologic symptoms, but the mechanics are the same. So let's go down to the answer choice. D. Flexion opens up the lateral foramina. A and B, extension worsens symptoms, right? C, downhill is going to increase lumbar extension because you're trying to keep yourself back over your heels so you don't fall forward. So all of these are 26. I know, dude. I know. I'm sorry. I'm trying to be quick though. It's only 8:30 and we're 10 in. Woo! I'm killing it. Yeah. So flexion, lateral stenosis, flexion is going to be better. It's also true of facet joint dysfunction or facet arthropathy. Okay, number 11. A patient with multiple sclerosis reports worsening symptoms after a hot shower and during exercise. Which intervention modification is most appropriate based on that information? 9:30 on the east. It's Passong's bedtime. Sorry. A, schedule frequent rest breaks and cooling. B, avoid exercise entirely. C, increase intensity gradually. Or D, emphasize eccentric strengthening. I'll read that one more time because I feel like I laughed in the middle of it. A patient with multiple sclerosis reports worsening symptoms after a hot shower and during exercise. Which intervention modification is most appropriate? A, schedule frequent rest breaks and cooling. B, avoid exercise entirely. C, increase intensity gradually. Or D, emphasize eccentric strengthening. Yeah, we're about halfway through our questions. If you have people, friends that you're thinking of, or classmates that you're thinking of that you think would benefit from just some MSK neurocardiopulmonary review before boards next week, feel free to share this live with them. Let them know that I've got one more coming up next Sunday at 8 p.m. Central Standard Time, just to try to help you guys feel as prepared as possible for your boards. By no means do I think I am the primary reason anyone passes their boards. I just want to be a resource for you guys, especially hopefully something that can be a little bit more specific to your studying rather than like the mass of information that a more rounded company like Final Frontier or Score Builders or something can provide for you. And if you hear my daughter, she just got put to sleep, so please forgive the crying. She's just going to cry it out for a little bit. Uthoff's phenomenon. Good, Quarter. I was going to give bonus points, which means nothing on here, but up here in our brains it means something. Uthoff's phenomenon, heat temporarily worsens symptoms, right? So increasing intensity will just worsen fatigue, even if you're gradual about it. Increasing the intensity of exercise is going to worsen fatigue. There's no need to avoid exercise entirely because we know exercise is beneficial, and perhaps they will worsen more quickly if they're not exercising. And eccentric focus does not address the main issue at all. The main issue is that they're overheating, and performing eccentric strengthening isn't going to change that. 12. A patient with CHF presents with bilateral ankle edema and shortness of breath with minimal exertion. Which position best reduces dyspnea? A, supine. B, Trendelenburg. C, hook lying. Or D, upright sitting. I'll read that one more time. A patient with congestive heart failure presents with bilateral ankle edema and shortness of breath with minimal exertion. Which position best reduces dyspnea? A, supine. B, Trendelenburg. C, hook lying. Or D, upright sitting. Trendelenburg position is, so like if this is flat and my hand is the head of the bed, I'm going to tilt them this way to get their legs above their head. So you will see this in the hospital in patients that are not, like, their blood pressures aren't stabilizing in supine, and so it's just a quicker way to get them stable from a blood pressure standpoint. And yes, it's the exact same name as we call the hip drop whenever someone has glute med weakness. Okay. There's several people. I haven't gotten a bunch of answers yet, so I'm going to wait a little longer. Guys, if you're new here, I am a big believer in regularly engaging with the content, so that way, whether you're right or whether you're wrong, it's going to stick in your brain better because you will have engaged with it, which means there's a connection being made between just like passively reading something and actually actively engaging in it. There's research to support that too. If you want me to argue about it, I 100% will, and I'll go find the research to show you. I'd look over that for sure. You'll see it on the TA cardio sections. Cool. Okay, let's go ahead and go over it. The answer is D, upright sitting. So upright sitting is going to decrease venous return and decrease the likelihood of overloading the right side of the heart, right? So supine and Trendelenburg and Hochleiden are all going to increase preload, which means that the right side of the heart is going to get very bogged down. It's going to have a hard time getting all of that blood pushed through the pulmonary arteries and over to the left side of the heart. That can cause pulmonary congestion and lead to worsening dyspnea. So I know that might seem odd because I know that we often think of pulmonary congestion being a left-sided heart issue, but keep in mind, if I have increased preload to a malfunctioning right atrium and ventricle, it's trying to pump blood hard enough to get it through the pulmonary arteries, through the lungs, and back into the left ventricle, but the right side doesn't have enough power to push all of that preload, like pump hard enough to force it all the way through the lungs, right? So it's going to pool up in the lungs and worsen the dyspnea. It's not just that it can't keep up with the venous return to the heart, it's that it can't pump. It's not strong enough, or it's not functioning properly enough to be able to pump blood all the way through to the left atrium and left ventricle. 13. Which finding best indicates a rotator cuff tear? A, painful arc. B, weakness without pain. C, pain with resisted internal rotation. Or D, full passive range of motion with painful end range. The answer choices, or the answer submissions, have drastically slowed down. We read it one more time. Which finding best indicates a rotator cuff tear? A, painful arc. B, weakness without pain. C, pain with resisted internal rotation. Or D, full passive range of motion with painful end range. That's funny. Okay, let's go ahead and go over the answer choice so we can talk about my thought process. And then I want someone, it doesn't have to be everyone, I want someone to make an argument for the answer choice that you guys are putting. Because I know what makes sense in my head, and now as I'm looking at this, maybe I didn't give you enough information. So let's talk it through, and if it looks like we're just making mistakes, then that's fine. If it looks like I did a bad job writing the question, just tell me. So my thought process with this question was that A, C, and D could just as likely be tendinopathy or impingement as a rotator cuff tear, right? But B is the only one that's like, if I have weakness without pain, and we're looking specifically at rotator, like if I'm suspecting rotator cuff tear, which of these is going to best support that? If I have weakness without pain, that's indicative of a full thickness tear. Painful arc is a part of a rotator cuff tear cluster, but could also just be supraspinatus impingement, right? And then once we get up to that 120, the humerus falls down or inferiorly in the glenoid and relieves that pain. Pain with resisted internal rotation, that could also be impingement, right? Or just subscap tendinitis. Full passive range of motion with painful end range could be, depending on what direction you're going, that could be painful, right? If it's a tendinopathy. But weakness without pain is the only one that would give me the most information saying like, okay, it's a tear and not tendinopathy and not impingement. Does that make sense? Yeah, Mia, you're right. That makes sense. I think the fact that painless only being full thickness threw me off. Yeah, yeah. So maybe it was just a bad question on my part. Maybe I didn't give you guys enough information. I didn't give you much of a stem, right? So that could have been my bad. So I felt B was an option, but I couldn't argue it being correct over C. Okay, sure. I guess in my head, I would have also thought like the stem doesn't exactly set you up to be like, okay, we're only thinking rotator cuff, right? So if someone just walks into my clinic and these are the things, like if pain with resisted internal rotation is one of the only bit that I got, do you think they will emphasize full tear in NPTE? I think it's possible. I don't think they're going to give you something to intentionally trick you. They just want to make the goal of the NPTE is to make sure that they're not licensing anyone that wouldn't be a safe clinician. And so I don't think they're intentionally trying to trick you. I don't think it'll be a major emphasis, but I do think that it'll be possible that they'll want you to be able to weed out full thickness from partial thickness. So again, my thought process with this was just to be like, which finding best indicates a rotator cuff tear? So when I'm looking at all of these, which one is going to tell me, yeah, tear, not impingement, not tendinitis? I think they'd likely throw this question into a case scenario. Yeah, you're probably right. Like they might give you a bigger case and then ask you multiple questions about that case, and this will be one thing. So you could be right about that, Rhea. Does anyone have any more thoughts about this, or are we ready to move on? I don't want to take up too much time with the confusing stuff. But if you guys are good with it, we'll just go ahead and move right on. This, and like I said, maybe this was just a bad question, but hopefully you guys can see my thought process. And I think either way, the information got across. The answer was B, weakness without pain. Is it C or A? So it's not C or A just because a painful arc could just as easily be indicative of tendinopathy or impingement. Pain with resisted internal rotation could be just as indicative of tendinopathy. And then full passive range of motion with painful end range, depending on which direction, it says full passive range of motion. So pain with external rotation could be putting some pain through my subscap tendon, or pain with internal rotation could be my infraspinatus arteries, my under tendons, things like that. So that was my thought process. We'll go ahead and move on because I feel like I've belabored the point at this point, and user has to go to bed soon. So move on to one of our neuro questions. A patient presents with sudden ascending weakness and absent reflexes following a recent viral illness. Which diagnosis is most likely? A, ALS, B, myasthenia gravis, C, Guillain-Barré syndrome, or D, multiple sclerosis? Yeah, of course. Of course. I just want to say, Lou, you're right about pain being present throughout active range of motion. On this last one, last thing I'll say about this, full passive range of motion with painful end range. And so really my painful end range was just thinking if one of your tendons is by getting put on stretch and it's got a tendonitis, that could be painful. That was my only thought there. So let me read number 14 one more time. A patient presents with sudden ascending weakness and absent reflexes following a recent viral illness, which diagnosis is most likely ALS, myasthenia gravis, Guillain-Barré syndrome, or multiple sclerosis. And a lot of you have already answered, so we'll go ahead, unless anyone wants to just spam the comment section right now with answer choices. We'll go ahead and go over it. C, Guillain-Barré syndrome. So a hallmark sign of Guillain-Barré syndrome is rapidly ascending bilateral weakness, right? You're going to get areflexia because it's a lower motor neuron symptom, and post-infectious. So GBS is usually triggered by some kind of virus, right? C. jejuni and upper respiratory infections are incredibly common. Glove stocking distribution, that's right, Dr. Trent. ALS is progressive, but it's not acute, so I wouldn't expect this rapid onset, like saying sudden ascending weakness. I wouldn't expect that in ALS, even though it's progressive. Myasthenia gravis does have weakness, but it improves with rest. This says it gets sudden ascending weakness. It doesn't talk about any episodes of rest, so I'm not even thinking about myasthenia gravis. And then MS would show upper motor neuron signs and symptoms, not areflexia, but hyperreflexia, right? Glove stocking distribution, bilateral symmetrical. Correctamundo. Nice. GBS and all the symptoms. Very good. Write that down, user. Write that mnemonic down. All right, number 15. A patient with pneumonia demonstrates crackles in the lower lobes and decreased chest expansion. Which intervention is most appropriate? A, incentive spirometry. B, pursed-lipped breathing. C, Valsalva maneuver. Or D, breath holding. I'm a PT, and I think you have great questions and do a good job of explaining your rationale. Thanks, AD. I like that your name on TikTok is AD for assistive devices or autonomic dysreflexia. But no, I appreciate it. I try to put a lot of thought into this. If I make mistakes, I don't want to be the kind of person that thinks, no, I don't make mistakes. Come on, it's you guys. No, I know my questions aren't perfect, and so I just want to be realistic. Look at you guys. Okay, still getting some answers getting put in, so I will wait a little longer. Would they have hypersensitivity, Reba asked. Potentially. They might develop as symptoms subside in GBS. They may develop things like allodynia or hyperalgesia, but it's not typical in the acute stages of GBS, Reba. I'm assuming that's what you're meaning. Those incentive spirometers are like candy in the hospital. Open glottis coughing, take out secretion sputum. Okay, I like how you guys are thinking. Let's go ahead and go over the answer. So the answer is A for two reasons. They give us two things in the stem that give us concerns, right? So they've got crackles in the lower lobe, so we're not having effective sputum production, right? Quarter set A, so light work. The other thing that we got to worry about is decreased chest expansion, okay? So we need something that's going to address both of those things. Chest expansion, not alveolar expansion, right? So let's think about that. Pursed lip breathing is, we know it's effective in helping clear sputum, but pursed lip breathing is not focused on improving chest expansion. Yeah, I wanted to make this one a little bit tough. So incentive spirometry is going to help improve chest expansion. It's going to help clear airways because it's giving time, right, for air to get behind that sputum, and then we can productively cough it up. and it's going to prevent atelectasis. That's one of the big concerns we have to have with decreased chest expansion, especially in pneumonia, is people ending up with a collapsed lung. And so that's one of the more emergent things we have to make sure we're managing in our patients with pneumonia. Pursed lip breathing may help clearing sputum, is not as effective at promoting chest expansion. Valsalva is ineffective and generally speaking is contraindicated, and breath holding would also be ineffective. So, any questions about that? My strong area, so I got you, brother. Yeah, you two just take the test together and it should be fine. Okay, let's see if you guys like this one. Number 16, which structure limits excessive hip internal rotation? A, iliofemoral ligament, B, ischiofemoral ligament, C, pubofemoral ligament, or D, ligamentum teres? Porter, I think you have a number one fan. Give you guys some time. I hate MSK. I know. We gotta know it at least for our boards. Mia, do you know what setting you want to go into? Like, are you planning on being in acute care or peds or neurotherapist or anything like that? Thank you guys for interacting. Appreciate you submitting your answers. We'll keep on waiting for a little bit longer. I love the sniff. I'm an outpatient neuro guy myself, frankly. I went on 2 inpatient rehab rotations at some really intensive inpatient rehab. OP geriatric vestibular is what I'm leaning towards. That's me. I'm like working further and further into a vestibular specialty. So that's awesome. Helps with test anxiety. Oh, thank you for this. Of course, dude. Yeah, well, unfortunately, you'll know this as you get into geriatric vestibular. A lot of our patients have MSK stuff anyway, so even though we don't have to know it to this extent, it's still important that we know some about our MSK, right? Unfortunately. SNP is fine, but my SNP rotation was so much heavy lifting, 100%. Iliofemoral limits hyperextension, pubo limits external rotation, abduction, extension, external rotation. Okay, let's talk about it, my friends. A lot of you are thinking good thoughts right now. Ischiofemoral limits internal rotation and extension. Okay, so B is the answer. Iliofemoral is going to limit extension and external rotation. Pubofemoral limits abduction external and extension. Ligamentum teres, or your round ligament, is going to stabilize the femoral head and the acetabulum. I'm glad none of you, I don't think any of you said D. Who asked to lift a bilateral BKA patient that weighs over 300 pounds? Yeah, that sounds not super fun. I had a bilateral BKA in outpatient that, oof, he was tough. I loved working with that guy, but he was tough because he was big and weak. And he laid in bed most of the time at the nursing home that he lived at. Emma, what's up, girl? I haven't seen you yet, so good to see you. Okay, let's move on to number 17. A patient with Parkinson's disease demonstrates shuffling gait, decreased arm swing, and freezing during gait initiation. Which intervention is most appropriate? A, strength training of hip flexors, B, passive range of motion exercises, C, prolonged static stretching, or D, auditory cueing during gait? This one should not be hard whatsoever. Excuse me. So let's go ahead and jump into it. External cueing bypasses basal ganglial processes. Okay. So the reason that Parkinson's rehab is effective is because I have Neuro practical in a couple days. This is perfect. What's the question? The question is, the patient with Parkinson's disease demonstrates shuffling gait, decreased arm swing, and freezing during gait initiation. Which intervention is most appropriate? So the reason that Parkinson's rehab is effective is because they still have their cortical processes, and so they can utilize M1 to overcome the unconscious processes of the basal ganglia. When you and I walk, it's an automatic process. We don't have to make sure that we're consciously taking large steps all the time. We're not having to think about how big, because the basal ganglia manages all those automatic processes for us. But once the basal ganglia starts showing deficits, we utilize M1 to consciously overcome those things. And so using auditory cues is going to help bring an external stimulus or an external cue to how they're meant to be moving, and that's going to help M1 kick in. Do you and other PTs in chat like the McKenzie approach? I'm a terrible person to ask because I am an outpatient neuro and vestibular PT. I do have a buddy who's half ortho, half vestibular, and he swears by McKenzie for like the whole body. He lives up in Chicago. Works at a clinic in Chicago, and he and his bosses he is getting McKenzie certified. His bosses are McKenzie certified, and they swear by him. Strength training of hip flexors. Strength training alone is not going to help break bradykinesia. Passive range of motion exercises aren't going to help generally. Prolonged static stretching. If you read the Parkinson's CPG, flexibility training is one of the lowest levels of evidence in terms of what we should be incorporating into our treatment sessions. So these will probably never be the answer on a Parkinson's question. Sorry, my mic died. I'm just going to have to pull that out. Can you guys hear me now? Am I back? Okay, yeah, I'll have to do it without the mic now. I was answering Trent's question. My go-to auditory cue gate song is Staying Alive by the Bee Gees because I really like The Office, and I like incorporating that into healthcare as much as possible. Hey, congrats, Gordillo. Congrats, Austin Gordillo. Super, super glad that you passed. And thank you guys for getting me back on track. But cool. Austin, you're the third or fourth person to come in and tell us that you passed. So you guys had a very successful cohort of PTAs taking the boards this year, which is awesome. Yeah, dude, of course. I love The Office. It's one of my favorite songs. In fact, a fun fact about me is that I have won runner-up and first place with a group of buddies that I had in office trivia at a coffee shop. So, okay. I don't know if anyone answered this question. I was scrolling and then I had my audio cut out, so. Okay. So the answer is B, right? Because COPD patients, a normal range or a not uncommon range for COPD patients is at 88 to 92%. A is not indicated at this time. You don't, with COPD, you don't want to just immediately go into oxygen because, again, the issue isn't that they're not getting enough oxygen in, it's that they're not getting enough CO2 out. So this is not usually the first thing that we go to with our COPD patients. COPD is not an acid-base diagnosis, so that's why C is not right. And then it's not a contraindication to exercise because it falls within the expected range for patients with COPD. Let's move on to number 19. A patient with de Quervain's tenosynovitis would most likely have pain with resisted wrist flexion, thumb extension and abduction, finger flexion, or forearm pronation. I'll ask that one more time. A patient with de Quervain's tenosynovitis would most likely have pain with resisted wrist flexion, thumb extension and abduction, finger flexion, or forearm pronation. Oh, and then I asked, I was asking you specifically, Trent, but then anyone can answer. What would your guys' go-to auditory cue song be for gait? Give me some good ones, because I can go in, my coworker at work has Spotify, and we've got some speakers around the gym, so I may just have him play some of your guys' songs tomorrow, or this week at the clinic. Okay, let's go ahead and go over this. Drop some songs in the chat of what you expect your go-to Parkinson's auditory cue song will be when trying to get them to speed up their gait. Okay. It's B. Tendons involved in de Quervain's tenosynovitis are adductor pollicis longus and extensor pollicis brevis. So, walking on sunshine. That's a good one. That would be funny. Uptown Funk is a good one. Walking on sunshine. That's funny. Okay, number 20. A patient following a stroke demonstrates intact strength but inability to perform learned motor tasks on command. This presentation is most consistent with A, stereognosis, B, agnosia, C, apraxia, or D, prosopagnosia. YMCA, that's a good one, Lou. I wanted to write a question mark. I'd write a bunch of these technical names in. I'll read that one more time. A patient following a stroke demonstrates intact strength but inability to perform learned motor tasks on command. This presentation is most consistent with A, stereognosis, B, agnosia, C, apraxia, or D, prosopagnosia. I need to remember these definitions. Okay. A lot of you guys have answered, so I'm going to go ahead and go through. Again, I encourage you guys to interact with the questions, because even if you don't have to get this stuff right? This is just me putting this on a Sunday night for you guys, and so don't feel bad about getting stuff wrong. But if you get it right or get it wrong, you're making the connection in your brain by actively interacting with the material, which is always going to have a bigger lasting impact than passively interacting with something like just reading. Okay? And yes, quarter. Well, presuming, right? So, like, we don't have any information that says they can do it automatically, but that doesn't we don't necessarily need that information to make the assumption. If I was, so the answer is C, apraxia. They can't perform purposeful motor tasks on command. Agnosia is the inability to recognize familiar items or people. Prosopagnosia is face blindness, so not being able to recognize people's faces, like familiar people's faces. And then stereognosis is the ability, not the inability. So it's stereognosis is the sensory ability to be able to recognize an object by the feeling of it without looking at it. D is Brad Pitt disorder. But yeah, ideomotor. So if this was asking me to distinguish between ideational and ideomotor, because it's just saying they can't learn motor tasks on command, I would assume ideomotor, but I also think they would give me more information if they want me to distinguish between ideomotor and ideational. Also good to see his YouTube vids and break them down. V Solus, you might be my like hype man, hype woman. I'll tell you what. Need to just have you guys be my like PR team. No idea, can't do it. That's exactly how hype woman. Sorry, Lou. That's exactly how I remembered this. Is with ideational apraxia, they have no idea how to do it, and so just keeping in mind, like even with it in their hand, like a hairbrush or a toothbrush in their hands, not being able to produce the movement. Okay. We're getting close, guys. So we are done with my MSK neuro cardiopulm rotation. Now I've just got some extra questions of some different systems I've thrown in. So, Desiree, I've got 6 questions left, and then I'll be done. I'm talking to my wife, just so you guys know. A patient presents with chronic unilateral lower extremity swelling following pelvic cancer surgery and radiation. The limb demonstrates firm, non-pitting edema with skin thickening. Which condition is most likely? A, venous insufficiency, B, acute DVT, C, lymphedema, or D, lipedema? Good deal. Good. Cool. All right. So she has a positive history of cancer in her pelvis. So this doesn't mean that they've got lymph node removal, but with history of cancer, there's always the possibility that they've done lymph node removal, right? But they've definitely done radiation in the pelvic area. And we're talking about unilateral lower extremity swelling, right? So likely looking at a lymphedema issue. Pitting is the edema is non-pitting, and there's skin fibrosis. So that's all pointing in the direction of lymphedema so far. Venous insufficiency is going to lead to pitting edema. Okay, so if it's venous insufficiency, it will be pitting. Another thing that isn't in the stem but would distinguish venous insufficiency from lymphedema is legs up. If legs are elevated, venous insufficiency the swelling from venous insufficiency should improve. With lymphedema, it won't. DVT is often acute, painful, erythematous, and warm. And lipedema is bilateral. So, it spares your feet and it can be painful. Good job. Stage 2, yep. Any questions about that one? If not, we're just going to keep on moving. Which intervention is most appropriate during the decongestive phase of lymphedema treatment? A, deep friction massage. B, manual lymph drainage with multi-layer bandaging. C, compression garments only. Or D, ultrasound to the edematous tissue. Dang, like 3 answers popped up at the exact same time. Okay, many of you are answering, so we'll go ahead and go over it. The answer, oh, that's wrong. The answer is not C. The answer is B. Complete decongestive therapy involves manual lymph drainage, compression bandaging, exercise, and skin care. Good job, Austin. Super proud of you, buddy. I'm glad that I got to be a part of your studying. Deep pressure massage can damage lymph vessels, so we wouldn't want to do deep friction massage, right? Garments are used mostly in maintenance, like compression garments only is used mostly in maintenance, not the decongestive phase. And then ultrasound is contraindicated in lymphedema treatment. So the answer is B. 23. Which finding most strongly suggests lymphedema rather than venous edema? A, swelling increases at the end of the day. B, pitting edema present. C, positive stemmer sign. Or D, pain with calf squeeze. Yes, yeah, sorry if someone was asking about. Short stretch bandages for lymph care. That's right, because they got high working pressure. Hey, babe. You got that? Thank you for doing that. Okay. Okay. Looks like you guys pretty much hit this with the lymphedema stuff, so make sure I don't have more explanation down here. Okay. So stemmer sign is defined as inability to lift skin at the base of the second toe or finger. It's specific for lymphedema. That is stemmer sign. So the answer is C. A is common with venous insufficiency. B is more specific to chronic venous insufficiency as lymphedema becomes non-pitting over time. And D actually is suspicious for DVT and not either. I mean, it could be in conjunction with CDI. Any questions about that one? You guys, looked like all of you guys got that one right. Okay, so now we're going into a few questions of multi-system involvement. A patient with diabetes and peripheral neuropathy presents with a plantar foot ulcer and decreased protective sensation. Which factor most increases the risk of delayed healing? A, decreased ankle range of motion. B, impaired sensation. C, decreased gait speed. Or D, mild lower extremity weakness. Sweet. Cool. All right, so the answer is B, because impaired sensation tends to lead to repeated unrecognized trauma and is a primary contributor to ulcer formation and delayed healing. So if we have decreased sensation, then that means that we probably have poor blood flow to the area, especially in a patient with diabetes, right? If I can't feel it, I'm probably more likely to have repetitive trauma to the area, which is going to further injure the area, further lead to decreased blood flow. The rest of this stuff is all secondary. So, 25, a patient with chronic kidney disease is referred to outpatient PT for strengthening. The patient reports fatigue and shortness of breath with minimal activity. Which physiological factors most contributes to these symptoms? A, impaired venous return. B, decreased VO2 max due to inactivity. C, altered motor unit recruitment. Or D, reduced hemoglobin concentration. I like it when there's more than one answer coming up on the comments, because that means that I wrote a better question, or a more challenging question at least. Okay. Give you guys a little bit more time to answer. Okay, this one's got a little bit more complex explanation. So chronic kidney disease leads to decreased production of erythropoietin, which then causes decreased red blood cell production, right? And so if you have decreased red blood cell production, then we have decreased hemoglobin concentration in our blood. So CKD does not primarily impair venous return, and deconditioning does not cause shortness of breath at minimal workloads unless it's severe, right? It'd have to be pretty severe. And then motor unit recruitment affects strength and coordination, but does not cause systemic dyspnea. So going back to the right answer, which is D, so hemoglobin is what oxygen binds to, so that way it can circulate throughout our entire body, right? So there's just sort of this cascade effect where CKD leads to decreased erythropoietin. Decreased erythropoietin leads to decreased red blood cell production, which means there's less hemoglobin in my body to circulate oxygen. And so that is the most likely, out of these 4 answer choices, that's the most likely contribution to these symptoms of fatigue and shortness of breath with minimal activity. And this isn't talking like cycling for 5 minutes, right? This would be like even something as simple as they got up to walk 10 feet to the mat and they've got fatigue and shortness of breath. Okay, last one. And I didn't even put an explanation because I think you guys will get it. A patient with COPD and osteoporosis is beginning an exercise program. Which intervention should be avoided? A, walking program, B, postural strengthening, C, repetitive trunk flexion, or D, upper extremity endurance training? Cool. Cool. All right, somebody explain why. The answer is C. Somebody explain why. Wedge fracture, compression fractures. You already got weak bones. Yep. Osteoporosis, you don't want to cause a compression fracture. That's right. Yeah, of course, Ryan. Of course, buddy. You guys have a good night. Compression of vertebral bodies, increased risk compression, absolutely. So walking is actually going to be effective in trying to manage both COPD and osteoporosis because you get loading of your bones, right, just through gravity pulling your weight down, and you get tensile forces from your muscles. So this walking can actually help stimulate osteoblastic activity, and it can help improve endurance in COPD, right? How often do you do this? I do this every Sunday at 8 p.m. Central Standard Time. I do want to let you guys know the board's exam for January is obviously the 27th and 28th, right? So I'm going to do one more next Sunday, and then I'm going to take a couple weeks off just so I have time to write this, like more questions, and then I will start probably the second week of February again. But I'm also hoping I can utilize the free time that I'm not writing these questions to make some more videos that I can post throughout the week during those course 2 weeks. See you later, user. So I'm going to take 2 weeks off, last weekend of January and the first weekend of February, and then I'll start for all of us preparing for the April boards. Of course, Quarter, you and Luis, you guys have a good night. Walking would be good. Postural strengthening would also be good because it helps take them out of that flexed posture, right? So less likely to get wedge fracture. Upper extremity endurance training, again, keeping bone density of your upper body. So repeated trunk flexion. Okay, are there any questions before we log out for the night? Always a pleasure. See you later, Trent. You have a good night, buddy. I'd love some referred pain pattern video questions in the future, but definitely take time for you. When are you doing Paris? Thank you, C. Solis. Can you scroll through 1 through 9? Lou, if you're cool with it, I will post these tomorrow. And I'm also going to post this live. I'll post it to my YouTube channel. So that way you guys can access it. My YouTube is underneath my profile picture or whatever on my TikTok account. And so I I don't have a test bank, Josiah. I actually write these myself. But yeah, Lou, I'll post this whole thing on my YouTube channel this week, so that way you guys have access to that. But if you guys don't have any other questions, I'm going to go ahead and sign off so I can get ready for bed and get ready for work tomorrow. But I'll do this again next Sunday, 8 p.m. Central Standard Time. I'll take a couple weeks break just so I can take some time to compile some more questions and content and stuff like that. And then we'll start again the second week of February. So I'll see you all next Sunday. Have a good night. If you guys have any questions in the middle of the week or you want me to help gear your studying, feel free to direct message me. I have taken some requests from people to look over their test scores so that way I can kind of help guide what their studying ought to be. If you guys want to do that, I'm more than happy to go over that with you guys as well. So you guys have a good night. I'll see you next week.